Okay, tamam. Welcome, Dr. Farah, and we start with Dr. Farah about anatomy of accessory and hypoglossal nervus.
Thank you very much for giving me the opportunity, and thank you the WFNS and also the Yemeni Young Neurosurgery Society to organize this workshop. Thank you very much, sir. So I will
Thank you very
share
much,
my
Dr.
screen.
Farah.
Sir, please let me know if my screen is visible and
Yes, it's
everybody
perfect.
can read. Yes, sir. Thank you. So 11th nerve is accessory nerve. This is a cranial part, coordination of the cranial nerve. So although it is started from the spinal root, but I just take this image just to again recap all the cranial nerve and where is our today's study is about the accessory nerve 11th and the hypoglossal is the 12th. So again is the cranial nerve and where it is originating and where it is located, actually better to say, on the cranium. This is a visual impression. So the 11th cranial nerve is known as the accessory nerve, which is primarily motor and both spinal and the cranial components. So it innervate two muscles, sternocleidomastoid and the trapezius muscle, which are essential for the head rotation, shoulder elevation, and certain neck movement. And the cranial part of the accessory nerve is often considered as a part of the vagus nerve and contribute the motor innervation of the muscle to the soft palate, pharynx, larynx, and adding to the phonation and swallowing. And sensory fiber is from the cervical plexus and it joined with the 11th nerve and providing some sensory input to the target muscle. So this is a visual impression of where this nerves is supplying. So it is sternocleidomastoid and trapezius, and there are also some muscle of the tongue. I find this picture is very interesting, and I think it is very informative for anybody who want to correlate with the anatomy. And it is just a blick that all the nerve and where is most important muscle innervations and the sensory innervation. So I think this is a very good takeaway picture for all the cranial nerve. I will explain and stick to our study today. So it is the pathway of the accessory nerve, and it is how I said it is a spinal root originate. It is from C1 to C5, or some variation is also possible, and in that case, it is cervical 1 to cervical 6. And the fibers from the spinal cord is ascend through the foramen magnum into the skull and then exit the skull through the jugular foramen along with the vagus nerve. And after existing the skull, the nerve descend and innervate the sternocleidomastoid and the trapezius muscle, which is superficial. So this is a image, actually, what I just said that it is a cervical pathway. So it is it takes it origin from the cervical 1 to 5. And it's go up and it's go through the in the cranial part is on the to the jugular foramen, and then it's coming out and it's supplied to the sternocleidomastoid and trapezius and also the small muscle of the tongue. So this is also an image reflect of the accessory nerve and the vagus nerve and the origin where it is, and then it is coming out from the jugular foramen and then supplying the sternocleidomastoid and the trapezius muscle on the back. And it also shows that they are having like it is coming out through with the vagus nerve through the jugular foramen. So why actually we are learning the origin, pathway, and clinical orientation of the anatomy is why so important. Because the patient come with the symptom. Patient can't say us, I have accessory nerve injury. So patient come with some symptom, and we as a doctor should analyze the symptom and should pinpoint that which nerve innervation is disturbed. So injury to the accessory nerve is result to the weakness and the paralysis of the trapezius and the sternocleidomastoid, which is leading to the difficulty of the shoulder elevation and impair also the head rotation and scapular wing and head dropping. So lesion may occur due to trauma, surgical injury, like on the posterior triangle of the neck, tumor, or when it is for the radiation hazard. Isolated injury, like as I say, isolated means one-sided. If it is injury, then patient come with one side shoulder paralysis, and the motor innervation is bilateral, and it is from the supranuclear level. So the unilateral is always give a light symptom, whereas the bilateral symptom is more prominent. And injury can be produce noticeable functional deficit. That means dystonia, neck and shoulder muscle rotation, or the drooping of the shoulder, or the patient can't shrug the shoulder. So this kind of symptom patient will come. This is very important picture for the anatomical correlation to understand when we dissect the nerve, how it's actually look like when we are dissecting origin, that it is coming from the C1 and C2, and it comes upward, and the cranial part is coming through the jugular foramen. So it is a image reflect. There is another dissection picture of the accessory nerve, that the spinal part is originating and it is going through to the cranial part. This is again for the image correlation, that what is happening on the spine, so that we always correlate with the image what we see in the book, and when we are dissecting and the operative field, it should be always correlate. So it's just an easy image reflect that what I just said, that it is the spinal part is coming from the C1 to C5, or in variation C6, and it's coming up to the skull and exit the skull through the jugular foramen. So this is a correlation. Another image and dissection, and this is very important, so that what we see in the book when we are dissecting, we can also correlate on the patient or the operative field, or when we are dissecting in the anatomy in the cadaver. All is very important to understand, not only the book image, but also to find out the structure in the dissection. So here is very nicely it is present that the sternocleidomastoid is already is just a level up. So it's like if we take the sternocleidomastoid here, so this triangle is showing us that where is our nerve. So here we can see that accessory nerve and the sternocleidomastoid. So here if we see the sternocleidomastoid, so this is our nerve. Another anatomical dissection to recognize the nerve. So the spinal component, and it's also supraclavicular nerve and external jugular vein and greater auricular nerve and trapezius muscle. So this correlation is very important, because it's not only detecting the accessory nerve or detecting the sternocleidomastoid or trapezius muscle, but also to be very careful about the other surrounding structure, because injury to the surrounding structure will also manifest clinically, and that is actually the complication. So not only recognizing the accessory nerve, but also understand the surrounding structure and memorize by heart is very important. So this is the spinal accessory nerve. And on the top, we have the laryngopharyngeal. This is also a dissection picture of the accessory nerve, and I find this picture very interesting because it's already said which is medial, lateral, and superior and inferior. That also help us to correlate the image what we learn from the anatomy book and actually what we see when we are dissecting a cadaver or on the living patient. So how I just said the spinal component C5, 6, and it is go up, and it's also here is the hypoglossal nerve, and this is a correlation of the muscle as well, so that we understand that where the nerve is going up, and from the jugular foramen how the nerve is also commonly coming up with the hypoglossal nerve. This is a image a reflect of the two like vagus and the accessory. So how we already saw in the dissection that it is very close to the internal jugular vein. So the cranial root of the accessory nerve is coming out, and it's all are coming going through to the jugular foramen. So it is also parallel to the vagus nerve. So it's showing a very nice anatomical correlation of the surrounding structure. Again, this is a radiological picture like CT, like MRI. If we see that where is our book image, so I suggest that if it is possible, always correlate with the book image with the practical image. That means MRI, CT scan, or dissection picture, so that one can really have a deep memorization of book image and while is dissecting or operating. So if we know that the back long muscle is the trapezius and the front is the sternocleidomastoid, and in between the external jugular vein. So if we can see that on the picture as well, that where is our, here is the trapezius muscle. If we just reflect that this is our trapezius muscle and this is our cervical vertebra, and from here is the internal jugular vein. So we can really correlate this picture with this radiological image. This is also our famous book, Neater. I take the picture because I find it very interesting. Whenever it comes for the neck dissection, it can be only even lymphoma dissection, or maybe a local swelling. It can be a lipoma. It can be lymph node. One should really understand the anatomical correlation, because it seems maybe lymphoma or lymph node is very simple dissection or very simple small operation, but one should have clear idea about the anatomical correlation, that what are the structure I am expecting after going through the skin, superficial fascia, and the platysma, and what else structure one should recognize. And that's how we can coming up to the less surgical complication. That means we can also be very careful about before extracting anything, or abscess drainage, or lymph node as a biopsy, or lymphoma excision. So the anatomical correlation is very important. So it is started from the superficial if we see that this extension of the neck is for the trapezius and front is the sternocleidomastoid. So from N, the mastoid is the upper triangle. Then if we start the dissection, so it is a very good dissection picture that after skin, we get some subcutaneous fat, and then the superficial veins are visible, whereas muscle is not yet dissected. And when we dissect the muscle, then it is very much visible, the trapezius, sternocleidomastoid, and then external jugular vein. And then it is very easy for us to recognize the nerve, vein, and the artery. This is the dissection picture, but is like more close up, just to correlate. Again, we dissect from the mandible as a like bony structure, if we just recognize as an anatomical landmark, and then when we dissect, we can find the accessory nerve and the sternocleidomastoid and the trapezius and the internal jugular vein. This is the spinal component, and it is coming up to the cranial part, to the jugular foramen. This is also a very important picture because this is a correlation with the hypoglossal and the vagus nerve, which we already see in the image, and this is a dissection correlation. So that's how I want to finish my the accessory nerve part. I should go quickly to my next slide presentation, and that is on the hypoglossal nerve.
Okay, that will be good.
Now it is visible, sir?
Yes, now it's visible. Perfect.
Okay, thank you, sir. Thank you. Okay, so I will go fast because I have only 10 minutes. So the hypoglossal nerve are the only pure motor, no sensory and parasympathetic component. So the nucleus is origin from the hypoglossal nucleus located on the medulla oblongata near midline between the pyramids and the olive, and the fibers emerge as a rootlet that converge to form a single trunk and exit the skull through the hypoglossal canal. So hypoglossal nerve, hypoglossal canal, it is very easy to memorize. Now we come through to the image that where is the hypoglossal nerve, where is the accessory nerve, and what I just described, that it is coming through to the single trunk, and then it is supplying only motoric of the tongue. So it originates from the hypoglossal nucleus, exit from the hypoglossal canal, and lateral relation is very important, lateral to the internal carotid artery and medial to the internal jugular vein. So when I was in a medical school, I always remember vein, like vein, artery, and nerve. That helps me to remember this correlation. So there are 4 branches, meningeal branches, descending branches, and thyroid branch, and the muscular branch. So here is the image to see that the meningeal nerve, which is supply the meninges near the canal, and the descending part is coming to the C1, 2, and 3. So the muscle innervation, because it's purely motor, so is muscle of the tongue, genioglossus, hypoglossus, styloglossus. Why is glossus? Because Latin glossus means tongue, and the intrinsic muscle of the tongue. And it's the movement of the tongue, that means articulation, mastication, and swallowing. Why actually it is important? Because the affected side can be, the tongue can be atrophy or fasciculation. That means the involuntary fast movement of the tongue, and where we can see stroke, motor neuron disease, neck trauma, or the surgical injury. And same as unilateral damage are the more have less symptom than the bilateral damage. This is a image correlation of the tongue deviation and where is affecting the unilateral, so the tongue deviation is only on the one side. This is a anatomical dissection of the hypoglossal nerve. So these are all the muscle. I have better picture. So this is the dissection picture, just to correlate that where is the hypoglossal nerve, where is the facial nerve. And we are again taking the mastoid, the sternocleidomastoid and the hyoid bone as the anatomical structure, and then from there we can correlate to the other surrounding structure. This is also the anatomical dissection of most of the cranial nerve and also the correlation of the cranial nerve. This is very important anatomical structure. Also the triangle where we can see the vagus nerve and the pharyngeal vein and the hypoglossal nerve. This is the image and how we can correlate on the dissection. So I put the image here so that it is very easy for the students to correlate with the dissection table. This is very interesting image reflect because it's like correlation of the anterior, posterior, superior, and the inferior structure. Once we can find out the muscle, then it is easily possible that we go through the muscle or the submandibular gland or the hyoid bone as a main anatomical landmark, or thyroid cartilage. Then when we deep dissect, then we can find out the hypoglossal nerve. This is also a dissection picture of hypoglossal nerve and also the correlation with the vagus nerve and the internal jugular vein. So this is a quick takeaway that it is originating from the hypoglossal nucleus, motor and exit from the hypoglossal canal. Branches are 4: meningeal, descending, thyroid, and innervate only the muscle. The palatoglossal, that means the tongue muscles, helps what is the function of the tongue, like speech, swallowing, and deglutition and the tongue movement. And clinical lesion can cause tongue deviation, atrophy, and fasciculation. So that is my slide presentation.
Thank you, Dr. Farah, for this presentation. It's a very nice
Thank you, sir.
presentation.